right, so my presentation is about a case study and it's titled Looking for Hashimoto Thyroiditis in a 22-year-old woman with an elevated TSH and normal PT4. So for background information, subclinical hypothyroidism is indicated when there's a normal serum free thyroxine concentration with the presence of an elevated TSH. Sometimes subclinical hypothyroidism can resolve without treatment, but it can also lead to overt hypothyroidism, especially if there's an underlying cause like Hashimoto thyroiditis. Um, in this case report, we have a healthy 22-year-old woman, and she was on no medication and without allergies. During a well exam, the patient had noted she had cold intolerance and hair shedding, but there was no thyroid enlargement noted. The patient's family history included her mother was diagnosed with Hashimoto thyroiditis at the age of 30 and underwent a partial thyroidectomy at 33 and a complete thyroidectomy at 44. For examination, the patient's TSH were slightly elevated at 5.01 with a T4 at 0.9. And that was at her first physical exam. The patient still noted that she had the same hair shedding and cold intolerance symptoms for 2 years. So after repeat exams, her TSH elevated to 5.52. T4 remained within normal ranges of 1.05, and her TPO antibodies were elevated at 177. Due to her increased TPO antibodies, the doctor followed up with an ultrasound where they noted a 2.5 times 0.9 times 1.8 centimeter hypoechoic nodule in her inferior left thyroid lobe. And an FNA indicated that there was a TP of undetermined significance with a scattered follicular cell arrangement in a slight crowding, indicating there is chronic lymphocytic thyroiditis. Since the FNA indicated a TP of undetermined significance, thyroid genetic testing was performed, and the malignancy markers were low, about 3%. For the patient treatment plan, the doctor prescribed her with levothyroxine for 50 micrograms orally every day, and with a follow-up for every 6 to 1 year to notice if her TSH level returned to normal, as well as to know if her cold intolerance and hair shedding has improved. The whole discussion of this presentation is there might be some benefits in early TPO testing, especially with patients who are suggestive of thyroid dysfunction and subclinical hypothyroidism. TPO testing can indicate Hashimoto thyroiditis that might have been missed when the subclinical hypothyroidism diagnosis was made 2 years earlier. And early TPO testing, especially in high-risk patients, that could decrease the symptoms of cold intolerance and hair shedding. And it might be helpful in decreasing the development of thyroid nodules. Especially now with TPO not being a standard of care when taking care of subclinical hypothyroidism patients. This case report argues that early TPO antibodies can be important, especially when Hashimoto thyroiditis is the reason why subclinical hypothyroidism is happening. This case report is also important, especially for women of reproductive age, as we all know that thyroid hormones are important for follicular development, the potency of the pregnancy, and having early TPO testing and identifying Hashimoto thyroidism earlier can mitigate these complications that might happen to females of reproductive age. And it's just another way of better supporting women when they are presenting with vague symptoms that are accompanying when it's accompanying the subclinical hypothyroidism symptoms. And yeah, that'll be all for my presentation.